all across the world, and a warm welcome to this APMEN Tech Talk webinar. It's great to see so many familiar names among those of you who registered. Let me just mention that I'm informed by Dr. Porn, sitting in Singapore at APMEN Secretariat, that so far we've had 308 people registering for this webinar. Typically, about half that number actually get around to participate. So even if it's 150, that's a good, strong number. It reflects strong interest, and it's great to have all of you on board. Thank you for setting aside time to join our community of vector control specialists listening in. This is probably going to be our last vector control webinar for the year, but we will resume again early in the new year. APMEN, as you may know, is the Asia-Pacific Malaria Elimination Network that supports our 21 member states across Asia-Pacific to achieve their malaria elimination objectives. And APMEN works very closely with APALMA, the Asia-Pacific Leaders Malaria Alliance, the political body of senior national leaders. And APALMA, together with APMEN, are both based in Singapore. So our webinar today is going to look at different aspects of surveillance, perhaps in a little broader context than we normally do, and not necessarily very narrowly, strictly vector focused, but I thought it would be good to understand a bit of the broader context within which vector surveillance sits. So we will look at surveillance through different lenses, but pull it back to vector aspects as we go along. So on behalf of all of us, I would like to thank our three speakers that will be sharing their particular experiences and insights with us. I'll introduce them in a minute. So the webinar process, we will have three, I hope, three PowerPoint presentations back to back, each about 10 minutes in length. This will be followed by a question and answer session. Our audience members can submit written questions during the presentations. Please use the question box. Please don't put your questions in the chat box, because we won't be tracking the chat box for questions. So please insert your questions in the question box. And then also, just a suggestion, if you have a particular member of the panel in mind that you would like to respond to your question, please precede your question with the name of the panel member you would like to respond to your question. So, for example, Prof. Leanne, and then your question. After the question and answer session, there's a very short poll just to assess your opinion of the webinar. It is very short, probably 1 minute of your time, but it helps us a great deal. And I'd be grateful if you can just quickly tick the boxes. It won't take you very long, 1 minute, maximum minute and a half. And it's a quick, just tick the boxes. You don't have to write anything. Please note that this webinar is being recorded, and it will be made available on the APMEN and the OREEN websites, usually within 48 hours. And you can access it. The details of these sites will be available on your screens. So I'm not sure if Dr. Camille has joined us. Dr. Camille Guillot is in Montreal, and it's very late at night, it's 11 p.m. There, but she doesn't. Camille,
hello,
you've arrived.
I am here. Yes,
Wonderful.
I'm very sorry. I had it for the 12th over here in Canada.
Oh my goodness. Yeah, no, that's great.
I'm
That's
so
very
sorry.
reassuring. Just a moment. Yeah. Okay, that's wonderful, Camille. Thank you. Sometime you can explain to me what happened there. So our first speaker will be Dr. Camille Guillot. I'm not sure how you pronounce your surname, Camille. I apologize.
That was perfect.
Thank you. And Camille will be talking on designing, or something around designing sentinel networks for vector-borne disease surveillance. And this presentation is not going to focus narrowly on vector surveillance, but rather a broader perspective on general disease surveillance and the factors that go into designing a good Sentinel network, of which vector surveillance is one part. So as vector specialists, we're going to get some bigger picture perspective, and I'm sure we will all learn and benefit from these insights. Dr. Camille Guillot graduated from Edinburgh Medical School in 2016. She returned to Canada to undertake a PhD in epidemiology at the Faculty of Veterinary Medicine, University of Montreal, working on the surveillance of Lyme disease. While completing her PhD, she began a residency in public health and preventative medicine at the University of Sherbrooke. Camille is particularly interested in surveillance of zoonoses using a One Health approach. So Camille, thank you for agreeing to share with us some of your research findings. We look forward to learning from you. Over to you, Camille, and thank you again. Wonderful.
Perfect. So I'll just share my screen.
Yeah, if you have problems, just ask Wulan and she'll pull it up.
Okay, perfect. So normally I think everyone should be able to see my screen.
And it's full screen as well, which is wonderful. Please go ahead, Camille. Thank you.
Perfect. So hi, everyone. So yes, my name is Camille Guillot. I'm from the University of Montreal. And that's where I'm undertaking my PhD as mentioned. And I'll present to you what is my first chapter, and it's relating to vector-borne diseases and sentinel surveillance. So very quickly, we'll go through the presentation plan just to explain why we had the questions that we did. I'll talk about methods. The majority of the presentation will be with results, and then we'll skip along to conclusions. Okay, so my thesis concentrates on Lyme disease, which is an emerging tick-borne disease in Canada. And as some of you might know, it resurged in the United States in the 70s, and it's really thought principally due to reforestation, which brought forth the establishment of tick populations. And since they've been spreading to Canada through spread of migratory birds. Okay? And Exodes ticks are the vector of Borrelia burgdorferi, and where the ticks go, Lyme follows. So they were first seen at Long Point, Ontario, which is right about there on the map. And then since then, they've really been spreading across the country. So the red spots are more or less correspond with the hot spots, but are for illustrative purposes. Now, Lyme disease extends at a rate of 46 kilometers a year, and that's mostly in the east of Canada. But as part of my PhD, I work with the Canadian Lyme Disease Research Network in the surveillance group, and my mandate was to create a pan-Canadian surveillance network. So essentially, here we have this huge country with a very heterogeneous expansion of the tick, because it depends on a lot of ecological factors, forest, presence of host. So we wanted to know where should we go out and sample these ticks. So we wanted to sample the vector in this condition. And there wasn't any framework in the literature to do so. So that's really how the scoping review was born. So a scoping review, for those who might know, is a fairly new type of review. And what it does, it scopes the literature. So we have general research questions, and it's looking for general answers. So in our context, we had a couple of questions. First off, for vector-borne diseases, in what context has Sentinel been used? And then secondly, using these case examples, can we draw out the criteria to guide Sentinel unit location? So then we had our search term very generally going on Sentinel surveillance, and we used a list of vector-borne diseases of public health concern as listed by the WHO. This is a Prisma chart to give you an idea. So we searched for databases and the gray literature. So we had over 7,000 articles, and from there we removed duplicates, had some exclusion criteria, and did relevance screening. So in total, we had 246 articles that we analyzed in more depth. Okay, so now we'll go on to the results. So from the articles, they covered, so we had a total of 24 different viruses that the articles looked at, 9 parasites and 3 bacteria. So the most common ones here, these are the top 10, but it was there was a lot of malaria, West Nile virus, and lymphatic filariasis. And then in terms of the vectors, they included mosquitoes, ticks, Tay fly, black flies, sandflies, snails, and midges. So there are mostly a bunch of species of mosquitoes, but we kept it quite general. In terms of the main methods used, for specimen collection and analysis, mosquito trapping was used in 73 of the articles, and then other methods were blood sampling either in humans or animals. It was serology, looking whether they'd been exposed to pathogens or not. But there was also, ELISA and PCR vectors, again, to look at presence or absence of pathogens, which were quite commonly found. So in total, so there were Sentinel networks that were composed of anything ranging from 2 sites to about 50 sites. So the sites where the sentinels would be placed, so they could be the sites themselves could be sentinels, or there could be sentinels animals placed there. The majority was between 6 and 10 sites, but the actual locations could be anything from villages, clinics, farms, a rural site, urban sites, zoos and kennels. So we had quite a range of different locations that were. Okay. Now, the main objective was to find, whether there was any criteria that were used to try to see where we should precisely locate the sentinel units. We came out with a total of 45 different criteria, which we regrouped into 6 categories. The most used one was the risk category, where we used a measure of risk to try to find where the locations would be. And examples are, for example, risk by human, so human cases, or again, risk with presence of vector. Afterwards, the environment as well was quite often seen, the second most seen category, looking at geographical features or having an ecology that's suitable for the establishment of vector. Population, referring to population density. So a lot of the time, sentinel sites try to maximize the population reached by the sentinel network, or again, otherwise population demographics or other characteristics of populations, like stability, instability, etc. Now, sometimes there was distribution. So within the study zone, did we want to use administrative boundaries or otherwise random distribution or even distribution within the sites? Past information refers to what we already knew about specific sites. So sites that had already been, or locations that had already been used in past surveillance or previous studies, or that had previous public health interventions. And then lastly, logistics are all, they're quite broad. So we had a logistic criteria referring to accessibility to the sites, or again, there were things like voluntary enrollment or stakeholders, presence of stakeholders. Okay. Now, so we had a whole bunch of criteria, but is there, was there some that should be used preferentially? And what we did is that in the data extraction steps, two reviewers used predetermined indicators in order to decide whether the Sentinel surveillance system were representative and sensitive. Okay, so we had kind of a question element to it, mostly assessed in a binary fashion, yes or no. Sometimes there wasn't enough information to do it, so it was mostly binary. Representativeness, as defined by the CDC, refers to the ability of the network to accurately describe the occurrence of a health-related event over time, and also its distribution in the population by place and person. Meanwhile, sensitivity refers to the ability to monitor change in the number of cases, pathogens, or vectors over time. So then we use logistics regression in order to decide whether any of the criteria came. So overall, for representativeness, it was variation in ecology across the different Sentinel locations. using Sentinel locations from past surveillance or previous studies, those that had public health interventions or used logistics criteria, and again, population density. Meanwhile, for sensitivity, only three criteria came out that seem to be associated with sensitivity, and these include using sites from previous studies, taking into account population density, and using the host animal as a risk, and that was often done through serology. Okay, so now the main challenges for this study. So we'll go over them quite briefly. So first of all, the search term really focused on diseases of public health concern. So some animal health diseases came up quite a few times, notably blue tongue. So we still included them, but they weren't the focus. And we didn't include any vector-borne plant diseases. The major limitation, however, is the surveillance system evaluation. So as briefly described, we use very broad proxy, and the evaluation of each network was done solely on the information that we could find in the article. And so we did it in a yes and no fashion. It's quite simplistic, and it may not necessarily be representative, but we really did it to get an essence or an overall feel of whether some criteria might perform better than others. It's worthwhile noting as well that the Sentinel system's ability to perform or not might not solely be dictated by Sentinel unit location. There might be other things that come into it. So in terms of conclusions, yeah, so the scoping review provides an up-to-date portrait of Sentinel surveillance for vector-borne diseases of public health concern. A main limitation was our inability to evaluate the surveillance system in depth, and for this we propose that a framework should be created similarly to a Prisma chart and really given every time a surveillance system is presented. And to give the reader the ability to evaluate the strengths and weaknesses of surveillance system. Now, as mentioned, we extracted a whole bunch of criteria, so 45 to be exact. We had some proxies, the logistics regression, a tool, but we believe we could optimize this tool in order to orientate researchers and public health authorities into which criteria. And for example, the creation of a decisional tool and a framework, a guideline, and that's really the next bit of my research. That's another chapter. And then lastly, it's once we have a few criteria. So normally on average, there were 3 to 4 criteria used, but how should we use them? So for the Canadian Lyme Sentinel network, we fueled them into a multi-criteria decision analysis, which permits to get stakeholders involved as well. So I'd like to thank everyone for listening. So it was a very quick and broad overview of the work, but I'll stay until the end. So if there's any questions, I'll be able to answer. So thank you for your time.
Camille, thank you so much. We realize that it's very late at night where you are, and we're very grateful for you staying up to give us this presentation. And it seems also willing to listen in for any questions, but we'll understand if you drop off. We're very grateful for your time. So Camille has given us this spacecraft helicopter overview. As vector control specialists, our audience has to undertake, many of you are from national malaria control programs, and you have to do sampling. You can't go and collect everywhere, all over the place, all the time. So you have to do sampling. You have to set up Sentinel sites. And if you want to do this in a scientific way, then there are certain criteria that you need to use to determine those sampling sites. And this is what I was hoping Camille would help guide us, to give us some idea of, selection of Sentinel sites. And I'd recommend if people are interested in that process of what should you use to guide you for Sentinel site selection, read up the publication that was put out by Camille. Camille, again, thank you so much. Our next speaker will be Professor Leanne Robinson, who will talk on the subject of village-level malaria heterogeneity and household risk factors. And here we are going to learn about the interplay of human behavior and practices and how it increases or decreases our risk of infection. You will once again recognize that much of malaria transmission relates to degree of human exposure to vector mosquitoes. It is what we do or what we don't do that brings us closer to vectors and to being bitten, and therefore the potential for transmission. And I'm sure we're all going to enjoy this presentation. Professor Robinson is a Senior Principal Research Fellow at the Burnett Institute in Australia, Program Director of Health Security, and also Head of the Vector-Borne Diseases and Tropical Public Health Group. Leanne holds adjunct appointments at the Papua New Guinea Institute of Medical Research. Leanne, and maybe you can tell us what WEHI stands for. I'm afraid I don't know. University of Melbourne and Monash University. And in addition, Professor Robinson is co-program director of several large vector-borne disease surveillance and implementation research programs. These include STRIVE, PNG, NatNat, PAVE, and the Asia Pacific International Center of Excellence in Malaria Research. All of this has made Leanne an acknowledged expert in malaria epidemiology and implementation research for the control and elimination of malaria and neglected tropical diseases. So Leanne, thank you for your time. We really appreciate it. Over to you.
Thanks very much, Leo, for that kind introduction and also for the invitation to talk today. It's a real pleasure to join you all. So I'll just share my screen. And is that good for you?
Full screen, wonderful, perfect. Thank you, Leanne.
Excellent. So as Leo said, I'll be sharing some insights from a large program of work that's looking to tackle malaria in the Asia Pacific region, and with a particular focus in this presentation on some data around village level heterogeneity and household risk factors. And the WEHI is the Walter and Eliza Hall Institute, Leo. So there you go. We all learn something new every day. So as Leo said, understanding the where, when, and who of ongoing transmission is essential in really guiding our efforts for malaria control and elimination. And it is pillar 3 of the Global Technical Strategy by WHO to transform malaria surveillance into a core intervention. And sorry, I'm just going to move you all so I can see my slide. Apologies while I do that. There we go. And this requires surveillance systems that can really accurately and reliably track the burden of malaria, and by doing so, target interventions to reduce that burden. And a deep understanding of the local epidemiology is crucial to inform the most cost-effective surveillance strategy for decision-making and intervention. And an important question that the field has really been wrangling over the past few years is how much effort needs to go into what we can't see. And this has really been a focus of the NIH-supported ISOMA program that Leo mentioned, that I co-lead with Professor Ivo Mueller, and involves studies across Cambodia and Papua New Guinea, where active population surveys and this whole suite of diagnostic tools are being applied to understand the epidemiology of transmission in these two very different settings, and to compare novel molecular and serological markers with the more classic epidemiological markers for their ability to identify areas and/or populations at high risk of malaria infections in space and time, to better understand the host, parasite, and vector factors that contribute to sustaining residual malaria transmission despite intensified control. And in Mondulkiri province, the team at Institut Pasteur Cambodia, led by Benoit Witkowski and Amélie Von Toit, have observed through both a cross-sectional survey as well as a longitudinal cohort, the analysis of which is still ongoing. But this is data here from the cross-sectional survey that they did, that transmission is really occurring in the forested areas and in groups engaging in forest-related activities. Residing in these villages that are either at the forest fringe, or actually in the forest, is associated with a much higher risk of infection. And this data really suggests that village level stratification of targeted interventions based on proximity to the forest and forest going activities or occupational risk really could render the elimination efforts more cost effective and successful in this setting. Similarly, across in Papua New Guinea, there's been a coordinated program of repeated community cross-sectional surveys and longitudinal child cohorts in 2 previously hyper to whole endemic areas of malaria transmission in PNG, in Madang on the north coast and Marprik in East Sepik province. And these studies, led by Dr. Moses Laman at the Papua New Guinea Institute of Medical Research, and a strong team of epidemiologists, vector biologists, laboratory scientists, and data scientists, is really combining those sensitive molecular and serological tools that I mentioned before with vector, demographic, and spatial data to calculate these various parameters indicated here and really try and understand the changing epidemiology of malaria under sustained control and provide this in-depth data to the National Malaria Control Program to really complement the more national level surveillance data. So the nationwide surveillance by light microscopy, which is shown here on the left, and these more in-depth community studies applying sensitive molecular diagnostics both show declining prevalence of malaria infections until about 2014, followed by an increase since 2015. Importantly, despite the overall downward trend in many areas, especially here on the north coast of Madang, where a lot of the work is done, it's really notable that the overall prevalence by PCR only ever reached just below 30% for all infections, 20% for PV, shown in red, and just under 10% for PF in blue. And furthermore, 70 to 80% of these infections were asymptomatic and low density, with 40% of them gametocyte positive and so potentially transmitting. So spatial analysis of this same community cross-sectional data across this period of time highlights that the increasing transmission has varied both between villages and within villages, and provides an opportunity to closely examine individual, household, and environmental risk factors. So in 2013, for example, the presence of clinical cases in the household were associated with a higher probability that more than 50% of household members were infected. By 2016, the prevalence of infections had actually returned to pre-control levels in 3 villages, shown here in red, Maui, Sengo, and Yenago. Prevalence had also increased in 8 other villages, but not to 2005 levels, whilst prevalence continued to decrease in Sanuhu and Warragum, highlighting a need to further investigate factors underpinning this spatial variation and the drivers for continued transmission in certain villages, which is work that's ongoing by this group here of Maria Ome-Kais, Aline Kattenberg, Shazia Rubal, and Dulcie Latu. Going back to the north coast of Madang now, and using data from the cross-sectional surveys that have been conducted there, Desmond Gull has been investigating the utility of key malaria indicators for the identification of hotspots of malaria transmission at the village level that might help to optimise malaria surveillance and response. In this study, the data shown here, generalised additive modelling was used to characterise spatial heterogeneity of malaria risk and investigate the contribution of individual, household and environmental risk factors. Hotspots for P. falciparum were more commonly observed than for P. vivax, with focal areas identified in 2014, expanding in 2016 as prevalence increased. And what you see here for the 2016 data is a base model and then a model where the risk of infection, or the adjusted odds of infection on this spatial layer, have been adjusted for household risk factors. And so in Megia, which is the village you're seeing here, this risk could be partially explained by household factors that increase risk of vector exposure, such as collecting outdoor surface water as a main source of water. Whilst in Mirap, which was the other village where Des closely analysed the data, the increased risk of P. falciparum infection correlated in 2016, that is, correlated with proximity to densely vegetated areas of the village in this area here. So the identification of household and environmental factors associated with increased spatial risk might serve as useful indicators of transmission hotspots and inform the development of tailored approaches for malaria control. And an important next step with this analysis is to be able to integrate corresponding vector and behavioural data into a combined spatial risk model to also see how much of this variation can be explained by that data. And the simultaneous collection of parasite, mosquito, and human behavioural data was an approach that was spearheaded by John Kevin, Michelle Capcicelle, and Daniela Rodriguez, who you all heard from a month or so ago in the 2016-17 TDR supported studies that we ran on the North Coast. And this approach continues to be what we undertake now for our continued isomer, community cross-sectional and longitudinal cohort studies. Because amongst other things, it has allowed us to observe that the peak biting time of the predominant anopheline vector in a certain village corresponds with a time when 20 to 70% of individuals in that village are exposed. They're not yet indoor, they're not under their nets, highlighting a clear gap in the toolbox for malaria control in PNG and in many settings in the Asia-Pacific region. Which is the need for additional tools to complement LANs and target outdoor biting. And to address this, PNG IMR, JCU and Burnett have recently commenced a collaboration with IVCC called NatNat, which is top piston for mosquito, to strengthen laboratory, semi-field and field capacity to test additional vector control tools in Papua New Guinea. And that's an ongoing program that it would be great to present to you all about another time. Another ongoing program, and as briefly mentioned at the beginning, a really important next step is to transition from using research studies to understand spatial heterogeneity and risk factors to strengthening health system surveillance to support real-time access to locally relevant data, which is the focus of our DFAT-supported Strive PNG program, which I co-lead with Dr. Moses Laman from PNG IMR, Mr. Leo Makita from the National Malaria Control Program in PNG. And this program supports the timely collection and aggregation of fever, molecular diagnostic and mosquito data from 8 Sentinel sites that are strategically located across PNG and uses a fit-for-purpose Strive to PIA data aggregation platform to combine this data and put it in the hands of those who need it. We use an explicit partnership-based approach that has facilitated strong leadership and engagement from the facility, provincial and national partners, and identified priorities for capacity strengthening, such as optimising the availability of meaningful data that can prompt action at the local level and strengthening molecular diagnostics capacity across multiple PNG organisations. And so this just shows you a very quick snapshot of some map overlays and data dashboards that are provided to national, provincial and district partners to give real-time access to locally relevant data through this Sentinel network. This map shows the number of febrile illness cases in a catchment around a Sentinel facility that's located here on the outskirts of Lae on the north coast of PNG. And it has interactive dashboards that allow you to drill down into the data from a particular area of the community in more detail. And communities with a higher burden of non-malaria fever, for example, could be targeted for additional testing to see whether there might be an arbovirus outbreak that could correspond with vector data that's been collected in the area. Any emerging signal could be further investigated. So this program is revealing critical insights into how to further tailor approaches like this to support decision-making and examining the cost effectiveness of a fit-for-purpose molecular informed Sentinel surveillance program to enable its consideration into routine surveillance and vector-borne disease program policy. So I'd just like to really briefly thank sincerely the study participants, families and community leaders from all participating villages and health facilities, and the strong support that this entire program receives from provincial health departments and the National Department of Health. And all of the very many, you can see this is a large collaborative program, the many collaborators that have contributed, especially colleagues at the PNG-IMR, but also those at the Department of Health and collaborating academic institutions globally. Thanks very much.
My golly goodness. Sincere thanks, Leanne. Absolutely fascinating stuff there. I mean, I could listen for another hour, and I'm sure you've got enough data to share for several hours, but truly fascinating insights there with lots of questions that could be asked. Can I just ask you quickly again, you mentioned the gametocyte prevalence rate, asymptomatic. What was that again? I missed that, Leanne. So
it was that 60 to 70% of those infections were asymptomatic, and of them 40% had gametocytes. 40%. Yeah.
Wow. Wow. That's very impressive. My goodness. Scary. Okay, Leanne, thank you so much. I'm sure we're going to have a good number of questions posed at you, but in the meantime, let's move on. And our final speaker is going to be Dr. Susanta Ghosh, one of our well-known and respected malaria entomologists all the way from India. Dr. Susanta is going to inform us about vector surveillance and control response in India, and some of the challenges associated with that, as well as some of the successes achieved by our Indian colleagues in the fight against malaria vectors. Dr. Ghosh is a retired director-level scientist and previous head in the National Institute of Malaria Research in Bangalore, India. He has more than 40 years of experience in multiple malaria-related fields, and also in lymphatic filariasis and arboviruses. He has 125 peer-reviewed publications to his credit. He is an editorial board member of 5 international journals, and he is still actively contributing as adjunct professor at NITTE University and also the University of Bangalore. Professor Susanta, it's a pleasure and a privilege to have you join us. Over to you. Thank you.
Thank you, Leo, with the good introductions, and I thank you very much and APMEN for this opportunity to share my experience for last 40 years. And I request to share my slides. One.
There we go. Thank you, Wula. Yes. All right, over to you, Dr. Ghosh.
Yes, next slide. Yeah. So my talk will be, next slide. Yeah, my talk will be in introduction. Then we had one WHO Regional Entomology Workshop in Bangalore 2018. Then global vector control response, which has been by WHO, then mosquito and other vector control response from India, and then vector control and responses, key questions and next steps. Next. See, the global scenario is very, very much disturbing, because if you see the report that 7 major vector-borne diseases combined, it is about to have, and most of them are parasitic infections, then arboviral infections. So, and then 100 countries, more than 100 countries affected by this, almost half of the world population. And mosquitoes are called the deadliest animal in the world. And I say that it might be misquoted. I think that human being might be considered that. But if you see the current, Indian scenario of vector-borne diseases, that that India is the second most populous country in the world, and over 135 crore, around 1.35 billion populations in 36 states of the Union territories. And you all know that in India, we are having 3 major diseases, parasitic diseases, which are malaria, then lymphatic filariasis and chalazial leishmaniasis, especially visceral leishmaniasis, is under the process of elimination. there are a lot of commitments and are there. And of course, now emerging diseases, arboviral diseases like dengue, chikungunya, and of course now coming Zika. And recently there were some outbreaks in 11 states. And then I remember the 28th last month, September, the high level committee was meeting. And some good news that 2 countries this year had been declared elimination of malaria, El Salvador and China, and adding to 127 eliminating countries since 1900. But the disturbing fact is that evidence of artemisinin resistance in northern Uganda, I think this is just published 2 weeks back in New Journal of Medicine. And another good thing that now WHO approved world first malaria vaccine, mosquito RTSS and this thing, but it will be again in children with moderate efficacy. Next slide. So this workshop, I was the local organizer, and then this outcome of this workshop has been published in the Journal of Vector-borne Diseases in December 2018 issue. And you can see that it was in our institute, and we had very excellent experience outcome of this. And I expect that such type of regional workshops will enhance our understanding of the disease and then what action must be taken. Next. And then you can see the thing is that the overview came of 2007 and 17, that what this workshop participant has given this. I'm just in brief that malaria, if you see everywhere it is down, but the dengue is being up. And then of course, Zika, other arboviral diseases, is there. And of course, I can tell you Maldives and Sri Lanka has been declared elimination by WHO malaria. Next slide. But the disturbing fact is that if you see the status of insecticide resistance, if you see, if I take 2 examples like India, I think all of the pyrethroids, organochlorines, carbamates, and organophosphate molecules and everything, all are resistant, like Sri Lanka. Now question comes, Sri Lanka, you can see the list of so many vectors are present, but still they are able to eliminate malaria. I think, we have to learn from them, and so resistance might not be the single criteria to, hindering for elimination. Next. So the key questions came, and that main issues were lack of skilled human resources I think in all Southeast Asia countries, 11 countries, need adequate trained staff, lack of infrastructure, limited institutional capacity, lack of internal coordination, surveillance may not be properly conducted, insecticide resistance and residual transmission. I think what my earlier speaker spoke about PNGen, etc. And then lack of networking, lack of advanced detection tool like PCR, ELISA, and RDT for sporozoites they have mentioned, and low priority of research. I think these are the major issues, and probable solutions have been given. Next. And then if you come to global vector control response, I think what it has been reflected by this workshop, it is nothing but the same thing they have reflected. There are 4 pillars of actions, and then the foundation is that strength, inter and intersectoral coordination, engage and mobilize communities, enhance vector surveillance and monitoring, and scale up and integrate tools, and then ultimately advocacy program, regulatory policies, and countries and leadership. These are very, very important aspects, and if you have to follow that, it will be helpful for all of us to understand that. Next. If you come to our Indian condition context, recently 2020, it has been MVCR has been guideline has been in place, and then you all know that there are 3 diseases under elimination, and then the emerging diseases like dengue, chikungunya, arboviral diseases. The main primary objective is that disease management, including early detection and complete treatment, integrated vector management, and then of course supportive intervention like BCC and public-private partnership, inter-sector convergence, etc. So these are the pillars which has been briefly discussed in this manual. Next. Then the thing is that, beautifully, I appreciate those who have prepared this map, and you can see that distribution of mostly 6 vector-borne diseases, how it is present. And you can see the eastern, UP, this UP part and eastern side is more dangerous, all the 6 diseases present. But additionally, the disturbing is that Kraft typhus, Cassonade Fordyce disease. I think this is the disease of very localized, but it is a disturbing thing. Now I am talking of Zika virus. This year, certain outbreaks came in Zika virus in Kerala, southern states, and in some parts of Maharashtra, Pune. Of course, this CCHF and then West Nile virus and Chandipura virus, they are a little localized, but it is a matter of importance. But again, I say that there are other diseases we should not neglect, like plague. Plague is still threatening, and those who are handling these vector control diseases, we have to think of that. Next. And if you see the overall, picture of this MVCR at the national level, the organogram which is being given from central to state level, and the major important part, we can say that IDSP, which is in 2004, it has been government of India, it has established, and they take care of all the disease, recording and this thing. And then rapid response team has been made, while local entomologist is a member, if there is any state level and district level. And then the major surveillance is done by this accredited social health activists like us, then at the local health staff, and then ANM and Anganwadi worker. They play a great role in surveillance, especially in disease. And then now, of course, some, especially in dengue, they are having surveillance in household level. Next. So there are flagship programs have been launched by the present government. I think thankful to them, present government, because Swachh Bharat Abhiyan means it's a wonderful program where cleanliness in program. But I can tell you that when you are doing the Swachh Bharat program, there we have to take care that we should not create more breeding sources for Aedes mosquitoes. When you are making more, there is one program called they make a lot of water storing tank and all. Smart Cities Mission, 100 cities in the countries has been selected for this. Ayushman Bharat, it is, I think, one of the prime healthcare program in the country. 1.5 lakh wellness centers has been done, almost 10 crore people with 50 crore population, providing about 5 lakh Indian rupees for treatment coverage. And then recently our Honorable Prime Minister has been given, like I think 2 weeks back, he has given the digitized mode of all these processes. And Mission Antyodaya, where underprivileged, deprived people, 8.8 crore household means you can multiply with 5, we can say. And then aspirational district program, I think in India we call Grama Panchayat, means village government. So there are 115 districts in 8,600 Gram Panchayats need special development activities. It's a huge program. And India, I can tell you, it's not a country, it's a continent. So we have got a lot of challenges ahead. Next slide. And you can see, I think I thank my friend, Dr. Pradeep Srivastava has given 20th August on a century of vector control in India. And I have taken this slide from him. You can see the present status of entomologists and their surveillance. I think it is very, very disturbing. So there are 84 entomological zones in the country, but hardly 40 are functional. But in between, under urban malaria scheme, I think there are about 131 towns and cities have been identified by a national vector-borne disease program. But there are biologists posts are vacant, and as a result, the entomologists which are in position, I can give example of Karnataka. I think the third Friday they have this program to go, and the urban program they take care of. And then kudos to them, they make this program very successfully doing. In between, what happened during these COVID situations, and I am very thankful to Absolute Human Care Foundation And Dr. Leo, we are giving a talk on that, and we enjoyed that talk. You remember that. And now that whole 43 sessions starting from 18 July to 19 December, sorry, 2020, it is not 2021 anyway. So we had made an proceedings, and these proceedings has given all the lecture notes. I think this an wealth of informations are there. If anybody want to buy these particular proceedings, you can log onto this Absolute Human Care Foundation website, and you can contact Dr. Srivastava or Dr. R.S. Sharma, and you can get this copy. So it is an I can say that it is an opportunity we created among ourselves. I'm also advisor in that particular foundation, and we all contributed many things. And really, it is an good thing that Dr. Dhingra and then Dr. Sujit Singh, he actually inaugurated that function. Next. And then question comes, vector control entomology and what do more. Again, I have taken this, and a lot of points have been given. Entomological surveillance in local ecosystem, then guidelines for architects. Health impact assessment is very, very important in projects and constructions. I know in Karnataka, there is an Upper Krishna project, and then we are involved somehow to guide them how to do it. And then, operational maintenance, like, this is a big, issue. Focused approach, like slums and resettlement colonies. There are a lot of in urban settlements, and again, the migration also is a big problem now. So solid waste management, vector control, then larval source management, entomological surveillance, is a huge challenge. And then we jointly published with Dr. Leo that APMEN newsletter, that wealth of human resources in India we have. But the problem is where we are lacking. The lacking is that we need more entomologists. When there was a Zika outbreak came, the Hindu, the newspaper, very national newspaper, the reporter talked to me and said, Dr. Bose, you tell me what do we need to tackle this? And red mark I have given. We do not have adequate number of trained entomologists now. So that is the major challenge now we are facing, the human resource. Anything we want to fight, we need a trained manpower. I think we have to develop that immediately to mitigate this problem. Next. Now the question is that I've given some important manuals. Please go through the manual. And this manual also Dr. Srivastava has mentioned, Compendium Entomological Surveillance and Vector Control in India, very nicely, taken all. But the basic, manual from WHO part 1, part 2 for entomology, especially on malaria, but, you can link with other. But again, I tell you that vector surveillance and control at ports and airports under International Health Regulation Act, then this guideline is very, very important from WHO. Another WHO guideline has came, genetically modified mosquitoes. When you talk of many things that, new technology must come and all these things. So how to tackle these situations, and then, but there are ifs and buts in between, and WHO has given clear-cut guidelines in this. I'll discuss next slide. Now, the thing is that, when I was working and then with different levels, and there are a lot of things. So my approach was, bottom to top approach, because our main target is the community. But to reach that community, we have to have understanding with the local government. So I had organized a meeting there in our institute to call the health secretary, health commissioner, directors, all decision makers. And at the state level, then the district level, and then also we have identified some very potential local NGOs. They took, they take very much active role in disease control and especially vector control, because their project was stalled because of the high malaria incidence in the early 2021 and all, and we have taken care of them. And then interacting with the community, you will learn many things from the community. It's very, very important to know from them what do they want and what action should be taken against that. And you can see I am discussing with the village community leader, the panchayat leader, and taking some decisions. Next.
Dr. Susanta, may I ask if you can start winding down, please?
Yeah.
Thank you.
Now the thing is that now innovations in vector control we have done. There is an model we have made for block level, and then we have done this method can be used for even our vector surveillance, and also digitized mass surveillance. We are now in place in Mangalore city, where disease surveillance and also vector surveillance and vector control are taken simultaneously. Next slide. Yeah. Now we can see that there are a lot of community activities and then responses from the local village heads. And then we have some improved method of mosquitoes growing in the laboratory. We have this article here. And then one of the visitors permanent were Dr. Sumesh Samnathan, now chief scientist in WHO, and also the earlier health minister visited our lab and discussed many things to go ahead. Next. And then the question is that, some observational thing it come out. When I was working, I was getting the report from Dr. B. Rao. He was the first director of NMEP in India. And then we published this paper because we found that species B of Pilusifaces, which is a very, and it presents that there are no malaria is that. And then we scientifically proven that they are having some restrictions of that oocyst level, which is called black spore of Ross. And if we have these molecular techniques now, we can identify all the 5 signaling species, and we have spotted that how signaling species can present and what action can be taken easily. It can be done with the very scientific interventions. Next. And then now innovative programs now come. When I was working in Gorakhpur in the Eastern UP, then this Dastak program they have made. And I also can tell you that if we have a ping revolution, because these pigs are important for amplifying host for Japanese encephalitis and all. And that would be a focal point if you take of that. Next.
Dr.
Yes.
Susanta, I'm going to give you 1 more minute, please.
Yes. Now the key questions I've given: vector surveillance, then IBM, how much to integrate. There are many methods are now coming. And then rotation of insecticide, the question is that is very eating. And then choose the correct fish for LSM, because I think that fish is a social vaccine. How to address community resistance, hesitancy for LLI and IRS. They feel suffocation. Sometimes they feel the net get burned. Then sometimes frequent net washing because of their cultural practices and leaking the net or the thing wall by the children. And then another important, prevent species invasion, because this Anopheles mosquito like Stephen's eye are invading many years. It has invaded in Sri Lanka and also in Eastern Africa. Next. Now the next step is that we need to strengthen entomological cadres, establishment of insectaries at the following all regulation this thing. Now, if you talk of new technology like genetically modified mosquito gene editing and all, we must follow the regulatory matters of the respective country. And there are a lot of methods are now coming, CNN methods, molecular taxonomy. But the question is that what is the classical geneticist, what is the classical entomology involved? And there are other things are not back here. We have to find out in other possible vector, rapid diagnostic tool like develop a parasite detection, then promotion of pink I mentioned, farmers program, proper cattle farming. We can, if you have proper cattle farming, definitely we can tackle many other diseases like KFD and other things. Need to understand transstadial transmission, which is especially for our health diseases. Bamboo flowering, you might be knowing that is rodent-related diseases like plague and other diseases. And know more about our success stories like, Daman in Odisha and recently published MEDP program in Mandla. You go to the literature, it just recently published in Transaction Wise Society. Next.
Last slide.
Yes,
okay.
And this is my publication. You can go through that. Next. Yeah. Now, take-home message is that community is the, take the lead, and we have to guide them how to do it. And they need to assess the ground zero related to fulfill the disease elimination goal. And I just giving an idea, a shift from public health to planetary health, reach to outreach, leadership with ownership, bottom to top approach for community approaches, go to the last mile to hammer the last nail of the disease coffin, because it is otherwise it's not possible. Next. And then my acknowledgement and their ICMR, then my all colleagues, and especially Dr. Pradeep Srivastava and Dr. Leo, Dr. R.S. Sharma, my community, several funding agencies, and my family, and just to say that. And last, this is a message of Mahatma Gandhi ji, there is enough on earth for everybody's need, but not enough for everybody's greed. I think we can save our planet if we just follow this message of this great man. Thank you so much.
Dr. Gosh, you're trying to squeeze 2 hours of presentations into 10 minutes,
Yes.
but you've done well, and a wonderful mix of big picture issues, higher level issues, policy guidance, and so on, and also mixing it with some detailed observations and issues. So thank you for that. And also what I found, well, I mean, I found it all interesting, of course, but there's some things very relevant for APMEN, such as you listed a nice page or slide on shortfalls and challenges. And that
Yes.
helps APMEN to identify where can APMEN maybe try and support or help, because many of the issues you raise are common throughout all national malaria control programs throughout Asia Pacific. So it's always useful to understand what are the bottlenecks and challenges that countries face. So Dr. Ghosh, thank you so much.
Yes.
Thank you to all 3 of our speakers for excellent, wonderful, fascinating presentations. I have no doubt we all learned from all of you, and we're grateful for that. Camille, I'm very conscious that it's now past midnight for you. I do not recall having seen any exact questions posed at you. So I'm going to ask you one question, and then I'll understand if you excuse yourself and go and get some much needed sleep. Camille, clearly, if the purpose of surveillance is to achieve early detection and distribution of diseases, there's a need to optimize geographic coverage and also the frequency of surveillance activities. So, you know, this all costs money, and it's not just the money issue, it's also the time and the manpower or human power. I'm not quite sure what the politically correct terminology is, human resources. So I know it wasn't a focus or an objective of your literature survey, but did you perhaps come across any indication, it's a big problem here in Asia Pacific, this issue of skills and capacity shortage. Did you pick it up as maybe a trend, or was there mention of it in the literature that you came across? Any comments about the challenges that face surveillance and Sentinel site setup, etc.? Any comments, Camille?
Yes, so in terms of Sentinel surveillance, I think that's the big strength of it, although it does come with its limitation, but a lot of the literature, let's say, moves towards Sentinel surveillance because Sentinels as such provide a restricted sample, but can be very cost effective. Now, the problem that we have with Sentinel surveillance in the literature is that for early detection, it isn't used very often. So for early detection of disease, it probably isn't the most optimal type of surveillance because we don't have, you know, the geographical coverage, and it's not the most sensitive, and that's the problem that we have in Canada. There's quite a good framework for tick-borne diseases published by Katie Clow in 2018. And it's in the spectrum of emergence. We can start off with perhaps passive surveillance as a kind of in-between measure, moving on with active surveillance to complement it. But even here in Canada and North America, it is a problem that when, you know, not necessarily for early detection, but when it starts getting no more of a problem, we don't have the funds. And then the problem with tick-borne is that if we've had to stop passive surveillance, but it could still provide important information so that emergence of other pathogens.
Wonderful response there. Very good points. Thank you for those insights, Camille. So Camille, of course, you're absolutely welcome to stay on, but at the same time, we also recognize that it's past midnight for you. At least I think it's past midnight. So
it is
if you...
past midnight, yes. I might say good night. I have a big day tomorrow, but thank you very much for the opportunity.
Yeah,
And,
no, from all of us, sincere, deep thank you for your time and effort, Camille. We appreciate it. Thank you so much.
see you.
Okay, good night to you.
Bye.
So then our team of our panel of speakers has been extremely good at responding. Leanne, you've performed miracles there in the background, responding to questions as they pop up. And there were some fascinating questions that you've already dealt with. And sometimes it's good to raise these questions for the benefit of the audience. So there was one question about, I mean, by Indra, I think it was, Indra Vitilangam, about simian malaria, or, so there are a good number of publications that keep coming out from Malaysia about, Nolzi and Cynomolgi and various other non-traditional so-called Plasmodium species. Do you have any insight as to the prevalence of those I'm not quite sure how to refer to them, but the other Plasmodium species in Cambodia, for example?
Yeah, thanks, Leo, and thanks, Indra, for the question. As I responded, yeah, I mean, I understand in that particular area of Mondulkiri province, it's something that's being investigated in a little bit more detail now. With some reports that there could be some Nolzi or other simian malaria parasites. So it wasn't something explicitly looked at in that study that I shared the data from in the presentation, but it is something that I know Institute Pasteur Cambodia with partners is looking at in a little bit more detail in some other in particular mosquito studies that are looking at collections in those forested areas and then identification of parasites. So that's about the most I can say about it. I think it wouldn't be surprising, that there could be. So we'll see.
I find it a fascinating topic, and Indra, you've done a lot of work on that, so it's a very interesting area, and I'm glad you published so much on the subject. Susanta, you, on a couple of slides, you pointed out this issue of lack of entomological and related surveillance capacity, which is a chronic problem throughout Asia Pacific, and in fact, globally, as the surveys in 2018 by Tom Burkott and Tanya Russell also pointed out, big problem. So it's one thing to do these surveys and understand where the shortfalls are. It's of course a completely different issue. So what do we do about it now? And I want to ask you, do you have any ideas of why it is that we have such shortfalls in the number of entomologists? Why is it an issue of there's not enough training, it's courses available, the universities aren't really offering entomology as a subject? Or is it because students aren't interested in enrolling in entomology because there's not a good career path, it's poorly paid, not many jobs available? Do you have any can you speculate for a moment why it is that there's this skills shortfall in entomology? What's your opinion, Dr. Ghosh?
Yes, it's a very key question, Leo, because now the thing is that, what you're asking, the question answer has been given in that particular editorial column, which I organized and this locally, WHO workshop. And this was echoed all the Southeast Asia countries. And I think, the thing is, it's a commitment at that recruitment level. If we have, I think we have two prominent academic bodies in the country, ISMOCD and National Academy of Vector-Borne Diseases, and Professor Das is the president of that. And then there are prominent people are available, but the question that coming to my mind is that why you are not able to recruit and train manpower where we have 1.35 billion people in the country. There's no dearth of resources, and at the government level we must think of that, how to promote this thing. Every meeting and conference with recommendation goes to the government, and I know my colleague like Dr. Srivastava and other, they can enlighten that. Even we have written to the government that we need to have entomologists in the place for vector control. I don't know why this is not being listened at that high level. I can give my one experience when I was just joined in last part of this last century. There was a project called Karnataka Health System Development Project, and that project director health services, they had projected few entomologist posts in that state, and you don't believe it that the project director, he just chucked off this entomologist post. He was saying, what is this? What is entomologist and all?
Yeah.
Then the director called me and here to help. I given a letter citing the WHO's importance of entomologists. Then the posts were created. This is the level of understanding of entomologists in there. There are many institutions, universities now coming up public health entomology courses. But the question is that when they will pass out, the career development is very, very uncertainties. Most of them now joining as a consultant. So the consultant, even Dr. P.K. Srivastava also earlier, he talked about consultant means what? There is no certainty their service will be continued.
Yeah, Dr. Ghosh,
So
thank you for that.
Yeah.
Yeah. So, yeah, but the fact remains there is this entomological shortfall. So, I mean, there was a couple of questions raised here from within the audience. Kerry Wilshire, could community members be educated to be entomologists? It's important to engage entire communities, address concerns. And then by Mohammed Musiki Bitu, how secondary school children can be involved in integrated vector management. So I agree with those comments, and there are issues that we should be looking at, and the APMEN Vector Control Working Group is doing that, but there is this shortfall, and we should be looking at innovative ways perhaps to address these issues. And perhaps the way to go is to try and devolve some of the simpler surveillance tasks down to community level. And you get these community health workers or voluntary workers and so on. So maybe one can tap into that community spirit where they can help with these things as well. So thank you for that. Leanne, I want to ask you, very often it's pointed out that, especially in Africa, the poverty-related issues of poor housing construction and how that leads to, but of course, Africa has the not unique, but the particular problem of Gambi and Funestus stricto being very strongly endophilic and also anthropophilic, so strong tendency to want to come indoors and bite indoors. And they will find gaps, eave gaps, windows are typically just a hole in the wall, cracks in the doors, poor housing construction, all poverty related, not enough ventilation, so people are inclined to sit outdoors and socialize outdoors and cook outdoors. So all kinds of issues that relate to, that end up in people being more exposed to vectors and vector biting, etc., especially when vector behavior is shifting to more outdoor biting and in earlier parts of the evening. So there's another whole set of NGOs and so on that are involved with development aid, trying to help relieve poverty. Are we in the malaria community doing enough to build bridges and try and encourage government agencies that you know, that could lend a hand with? What I'm trying to say is, if we can improve housing, we'll build out malaria in the process. And I think it's a known fact that as standards of living increase and people have better housing available, electricity available, etc., then malaria incidence declines. Do you think we should be better at trying to get government and NGOs, people involved with community development, and bring them together with Ministry of Health malaria control programs? Any comments around that, Leanne?
Yeah, look, I mean, I agree with you in that I think there is a, pretty strong evidence base now, really, that like closer linkage between health and development sectors, it really has strong advantages for diseases like malaria and other vector-borne pathogens, particularly, in the way that communities are engaged to lead on programs and implement solutions that will have, like you say, a dual benefit, in addressing a particular, element of either their house or their access to safe drinking water, improve their livelihood, but in doing so, also really improve their health and provide them with more options for potentially not spending so much time outside. I think what we have to be mindful of, though, as well, with some of that thinking is that, in certain settings in our region, and particularly in PNG, it's very cultural as well. People love spending time outside. That is part of the social fabric of the community, and the culture is to be outside, to be together in community activities and talking. So, I mean, I think it's obviously incredibly important, to have effective tools and evidence to guide their implementation. But I think it is really affected communities identifying how to best implement those new tools and interventions, seeing the benefit of them, not only on their health, but also on their livelihood, the opportunities for themselves and their families, and having communities really lead and champion the implementation and scale up of tools is clearly the only way that malaria elimination will be achieved, has ever been achieved. So yeah, I think it's a yes, but I think it's about doing it in a very community-centric, community-led way.
Absolutely. No, thank you for those perspectives, Leanne. So there are a number of other questions directed at you, Leanne, but I'm first going to circle back to Susanta. And I see you've been proactive and you've been responding to questions and typing in responses, and those questions have disappeared. So let me ask you, Susanta, India is still a little bit on the back foot regarding the still high levels of malaria that you face, although you're doing a wonderful job in bringing that down. But still, it's still relatively high, especially when you're related to what's happening in the Greater Mekong sub-region, where people are really enthusiastic and hopeful that we can achieve elimination by 2025, maybe, at least for falciparum. So malaria may be on the decline, even in your country, but arboviruses seem to be increasing and are going to take over from malaria as a serious public health threat in future. So can you just give us, you spoke about arboviruses amongst others, plague and scrub typhus and leishmaniasis and so on. But just give us a sense, are arboviruses on the increase and worrisomely so? And what is the country doing about it? What is happening with arboviruses in your country?
Leo, if you can see that, this particular vector arbovirus, mostly, Aedes mosquitoes, and then primarily they were urban vectors. Now you can see there are a lot of developments are happening in India. Urbanization programs are going on in India. And then this particular vector, it has got very immaculate capacity to, establish very quickly, and they can multiply, and their capacity of establishing is very, very high than other mosquitoes. And that is the reason, we must look at that, what we need to be done. And I have seen, and I can tell you in example in Karnataka, malaria is on the very, very vanishing stage, and you are correct. And the major challenge now we are facing this all dengue and chikungunya. And then, urban slums and all these areas. The major point I find, what are storing barrels now. If I request the government to look into this, and not only here, and I can find many images and pictures everywhere, these water storing practices has to be taken care of by the community. And what I was mentioning about that, such a Bharat Abhiyan, when there are toilets are making for defecation, handling, and it's a beautiful program came, lot of diseases have come. But what cropped up when I was visiting those areas, I talked to the district, administration. You are making these toilets and all, but you see that you should not create these mosquitoes, because you are making one cemented tanks outside the toilet for taking, storing the water. So such type of, knowledge gap between our health professional and that level, project, implementation level. Yeah. I'm giving this example, like, if you see the Bangalore, now Bangalore, if you see, is this year also I can find there are dengue is now coming. The problem is coming in that there are, we have sensitized the local authorities. Now these local health authorities, now they are coming up. And the problem lies, surveillance. In between, there are some breeding checkers, there are seasonal breeding checkers. So seasonality, breeding checker, disease doesn't, behave like that. And I can tell you, give me an example of Delhi. There, even in the cold season also, the Aedes larvae are in the overhead tank. But when this temperature rises, immediately they come up, and then you can see ovarian transmission immediately flashes up. And it is not the picture of India level. You can see Singapore also happened.
Thank you.
And now the question, now the question is coming, it is surveillance. I am just, received one article from Frontiers in Public Health. There are many traps are there, where it says, Gavi trap or fan trap, this BG trap and what trap, because they're still, very initial stage, what kind of surveillance we need to do. That's why I'm giving emphasis on container surveillance you do. And
we have to wrap up, Dr. Ghosh. Thank you for that response. There's lots to talk about, and certainly with the rise in arboviruses, the need for entomologists is not going to decrease. In fact, it's going to increase. So lots of opportunities for entomologists and entomological careers. I see Indra has mentioned that in Malaysia, they're going to be offering courses. It was up on the screen a little earlier, but it's disappeared, that comment. So it's good to know that. So I know we've almost been on the go for an hour and a half now. This is the last question. Before we wrap up, I'm going to ask that our audience members, we're going to have a little poll, and I'm going to ask, Wulan is going to put up that poll in a minute. And if you wouldn't mind just spending that, literally, it'll be about a minute, just filling in the poll questions. That will help us. Leanne, I'm going to ask you a last question. I know you have to leave as well. So thank you for your patience. I want to ask you the issue of repellents. That WHO seems to be a bit lukewarm on repellents, probably for the reason that it's never been proven very effective in malaria. reduction. You know, at best, you're displacing malaria, vector mosquitoes from biting you to go and find someone else to bite. And at a village scale, it means that there's no actual reduction in malaria prevalence. You're protecting yourself, but it really doesn't help much for others in the community. So in your work, working with communities and so on, what is your impression, Leanne? Is there a will, because it does work, repellents do work, but of course it costs money. It's not like bed nets that are often handed out free of charge. Repellents you have to buy yourself, and people living in villages do not have the disposable income to spend on relative luxuries like repellents. But your impression, are people willing to use repellents? Because they do actually work, and especially if you can get forest goers to use repellents. What is your impression? Anything to say about repellent use, Leanne?
Yeah, thanks, Leo. A couple of things quickly. One, which I'm happy to share in the chat after this, is that colleagues of mine working in Myanmar, Freya Falks and Win Hanu and that group, you know, did do a really excellent step wedge trial, you know, showing at the village level that personal repellent delivered through, you know, community-based malaria workers, you know, really did show efficacy at reducing the prevalence of malaria. So I think there is some evidence. As you say, we know it works, but at that village level, it's always been very, very hard to demonstrate. But I think that trial did an excellent job. The other thing I would say is this is, I know, an active area of investigation in Cambodia at the moment by UCSF working in collaboration with IVCC, looking at the use of personal repellent in forest packs. So I think we will see some more evidence come out that will answer that question, you know, that you just asked about, you know, how can we really try and increase uptake by those who would really benefit most, and forest goers, I think, are a really key population that could benefit. But it is addressing those issues of not only cost, because I mean, I guess that can be addressed if there's, you know, sufficient funding through the program to really provide repellent to targeted populations, that can be addressed. But it is also about acceptability and people being willing to use it. And certainly in terms of my reflections from the communities that we work with in Papua New Guinea, you know, we see relatively limited use of personal repellents in the villages where the work's conducted. And in some acceptability work that has really just recently sort of begun, the teams have heard participants raise concerns about you know, the smell of repellents, and not only of repellents, but also of coils. You know, we've asked participants about their perceptions of a number of different vector control tools, and the smell of repellents and coils, the feeling that smoke is a concern for people with asthma, that putting something on their skin is just, you know, not really something that they enjoy doing, is, I think, you know, still an issue. But there are also things that we'll be further exploring, you know, in that work that's ongoing in the NatNat program that I mentioned before. And I personally don't think they're things that can't be overcome with a good package of awareness and education. But I think it is going to be at that more at that key population level that you discussed, where people can really be targeted in a sense that because of this activity you're undertaking that's putting you at greater risk, you know, this is a really key intervention that you could use to protect yourself. I think that combination of providing the repellent with clear messaging could help.
Wonderful response, most encouraging, very positive words. Thank you, Leanne. So the time has come, unfortunately. So my sincere, deepest thanks to Camille, Leanne, Susanta, genuine, sincere thanks from all of us. I see there are still 91 bitter enders that are hanging in there, hanging on to every word you speak. So from all of us, thank you very much, Camille, Leanne, Susanta, and to our audience, genuine, wonderful to have such strong interest from all of you. Thank you for listening in. I see the poll is up and I see responses are gathering. So thank you for that. So also to our team, Dr. Porn, Tin, Wulan, sincere gratitude to you for your support and help. And very good wishes to everyone. Thank you for your time. See you next time.
Thank
Perhaps
you. Thank you.
early in
Yeah.
January.
Yeah.
Yeah. Thank you. Bye-bye now. Bye, everyone.